Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 197 of our Pharmacotherapy MCQ series, which majors in cardiology. And the first question reads, TKT, is a 67-year-old male patient who presents to your cardiology clinic for routine follow-up. He has a past medical history significant for ST segment elevation myocardial infarction, which occurred 24 months ago, depression, osteoarthritis, type 2 diabetes mellitus which is diet-controlled, and heart failure with reduced ejection fraction, abbreviated as HFR-EF with an LVEF of 25%. His current medications include aspirin 81 mg orally once daily, atorvastatin 40 mg at night, spironolactone 25 mg in the morning, lisinopril 20 mg orally once daily, carvedilol 12.5 mg orally twice daily, furosemide 80 mg orally twice daily, paracetamol 650 mg orally 4 times daily, and sertraline 200 mg in the morning. He has no known drug or food allergies. His pertinent vitals include a blood pressure of 130 systolic and 80 diastolic, a heart rate of 65 beats per minute. His pertinent labs include potassium levels of 4.5 milliequivalents per liter, serum creatinine of 1.6 mg per deciliter. His HF is stable and considered New York Heart Association functional class 3. So my question to you is, which of the following would be the best recommendation to maximize the management of TKT's HF? And the correct answer is C. Increase carvedilol to 25 mg orally twice daily. Maximizing guideline-directed medical therapy, abbreviated as GDMT, is one of the key roles of the board-certified cardiovascular pharmacist. However, not all GDMT options have improved benefits with higher doses. This patient has a well-controlled blood pressure with a heart rate less than 70 beats per minute and currently has stable HF. According to the Atlas trial, low-dose versus high-dose lisinopril showed no difference on the primary endpoint of all-cause or CV-related mortality, making answer D incorrect. Answer B is incorrect because increasing the furosemide dosing interval is not needed, given that the patient currently has no signs or symptoms of volume overload. Such an increase could lead to intravascular volume depletion, which could worsen his renal function. Although spironolactone has been shown to reduce mortality, no data exist regarding its impact on morbidity and mortality with higher doses. That makes answer A incorrect. Furthermore, the patient's blood pressure is controlled, and his serum potassium is 4.5 milliequivalents per liter. However, higher doses of beta blockers have significantly improved LVEF as well as reduced mortality. Thus, increasing the carvedilol dose would be most prudent because the patient has the blood pressure and heart rate for the dose increase, and he will have significant health benefits from the increased dose. Thus, answer C is correct. Please proceed to the next question. And the next question reads, TNA, a 68-year-old male patient presents to the cardiac intensive care unit with worsening dyspnea over the past 2 weeks. He has a past medical history significant for heart failure, with an ejection fraction of 20%, COPD, and hypertension. His pertinent labs include an on-admission N-terminal pro-B-type natriuretic peptide, abbreviated as NT-proBNP, of 8,800 picograms per milliliter, a serum creatinine of 1.0 milligrams per deciliter at baseline. Despite 72 hours of diuretic therapy, TNA remains dyspneic, but his serum creatinine rises to 1.8 mg per deciliter. The cardiac team inserts a pulmonary artery catheter, which reveals the following: pulmonary capillary wedge pressure 8 mm of mercury, cardiac index of 2.8 liters per minute per meter squared, and systemic vascular resistance 1860 dynes per second per centimeter to the power of -5. His pertinent vitals include a blood pressure of 110 systolic and 77 diastolic, and a heart rate of 82 beats per minute. His other labs are within normal limits. So my question to you is, into which of the hemodynamic subset listed below would TNA's disease best be placed? Would it be A. 4, that is cold and wet, or B. 3, that is cold and dry, or C. 2, that is warm and wet, or is it D. 1, that is warm and dry? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. 1, that is warm and dry. Although subset I is rare in patients with acute decompensated heart failure, it may occur in patients for whom therapies aimed at improving congestion are rapidly effective, especially in the presence of other disease states that may confound the presentation, in this case, chronic obstructive pulmonary disease. That makes answer D correct. The patient's NT-proBNP is elevated, which indicates some degree of volume overload, but this was adequately treated over several days, and he is now euvolemic, i.e., dry. That makes answers C and are incorrect. Over-diuresing patients may result in a cold state, but the patient's cardiac index, 2.8 liters per minute per meter squared, indicates that this is not the case, making subsets 3 and 4 incorrect. That makes answers B and A incorrect. Please proceed to the next question. Would it be A. furosemide 10 mg per hour by IV infusion, or B. bumetanide 2 mg per hour by IV infusion, or C. bumetanide 2 mg IV twice daily, or would it be D. torsemide 80 mg orally once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. bumetanide 2 mg IV twice daily. According to the dose trial, patients randomized to high-dose intravenous loop diuretic therapy, a 2.5-fold increase over their home dose, had decongestion more rapidly than those randomized to low-dose therapy, equivalent to their home dose but administered intravenously, with only a slight risk of transient worsening of renal function. The recommendations of the 2013 American College of Cardiology and the American Heart Association guidelines for managing heart failure reflect the results of this trial. Because the patient's home dose of bumetanide was 1 mg twice daily, an appropriate initial regimen would be 2 mg intravenously twice daily, a two-fold increase over his home dose administered intravenously. That makes answer C correct. Torsemide is incorrect. Oral formulations are not preferred during ADHF because of impaired gastrointestinal absorption. That makes answer D incorrect. The two intravenous infusions, bumetanide 2 mg per hour and furosemide 10 mg per hour, are incorrect because the total daily doses far exceed those shown to be safe as initial therapy in the dose trial. That makes answers B and A incorrect. Please proceed to the next question. And the next question reads, PLO, a 64-year-old female patient presents to your cardiac ICU. Her chief complaint is acute worsening of shortness of breath over the past 2 days after running out of her medications 14 days ago. She has a past medical history significant for dilated cardiomyopathy, with an ejection fraction of 25%, and hypertension. Her current medications include sacubitril co-formulated with valsartan 97/103 mg orally twice daily, carvedilol 25 mg orally twice daily, eplerenone 50 mg orally once daily, and torsemide 40 mg orally once daily. Her pertinent vitals include a blood pressure of 188 systolic and 110 diastolic, and a heart rate of 90 beats per minute. On physical examination, the following are noted. Crackles to 1/2 the height of the lung fields, jugular venous pressure of 14 cm, her extremities are cool on palpation. Her pertinent labs include a serum creatinine 1.4 mg per deciliter, the value at baseline was 1.0 mg per deciliter, and elevated liver transaminases. On presentation, the clinical team infuses 100 mg furosemide once. So my question to you is, apart from diuretic therapy, which of the therapies listed below would best be considered for PLO's acute decompensated heart failure ADHF now? Would it be A. Nitroprusside 0.2 micrograms per kilogram per minute IV infusion, or B. Labetalol 1 mg per minute IV infusion, or C. Enalapril 1.25 mg IV 4 times daily, or would it be D. Milrinone 0.25 micrograms per kilogram per minute IV infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Nitroprusside 0.2 micrograms per kilogram per minute IV infusion. The patient's disease is in subset 4, cold and wet, thus, treatment should be aimed at improving congestive symptoms as well as restoring end organ perfusion. Before running out of her medications, the patient was taking high doses of neurohormonal blockade, and her current presentation is likely a consequence of elevated systemic vascular resistance, as evidenced by her increased blood pressure, which can impair left ventricular performance secondary to increased afterload. Consequently, efforts to improve output should focus on vasodilation rather than inotropy, making milrinone incorrect. Answer D is incorrect. Although enalapril would reduce afterload through peripheral vasodilation, the patient already has compromised renal function, and enalapril administration might confound the monitoring of diuretic therapy, i.e., if further increases in serum creatinine occur, it will be difficult to discern whether they are because of diuretic therapy or enalapril. Answer C is incorrect. Labetalol is incorrect because it is a negative inotrope, which could further compromise left ventricular performance even if it improves systemic blood pressure. Answer B is incorrect. Nitroprusside is correct because it reduces afterload without compromising left ventricular performance or end organ function. Answer A is correct. Although the patient is at risk of thiocyanate accumulation in the setting of worsening renal function, the risk is low, given the doses and durations of nitroprusside commonly used in ADHF. Please advance to the next question. And the next question reads, MWT, a 58-year-old female patient was transferred to the cardiac ICU several days ago for the management of acute decompensated heart failure with volume overload. Although she received a continuous infusion of IV furosemide, which has since been escalated to 20 mg per hour. MWT has only been net negative by around 1 to 2 liters per day and remains symptomatic. On physical examination, crackles are noted to 1/3 the height of the lung fields. There is a positive hepatojugular reflux, with a 2+ lower extremity edema. MWT's mental status is unchanged from baseline. Her pertinent labs include sodium levels of 132 milliequivalents per liter, a serum creatinine of 2.2 mg per deciliter. At baseline it was 2.0 mg per deciliter. Her admission B-type natriuretic peptide 580 picograms per milliliter. Her pertinent vitals and liver transaminases are within normal limits. So my question to you is, which of the following would be the most appropriate strategy for augmenting MWT's diuresis? Would it be A. Tolvaptan 30 mg orally once daily, or B. ultrafiltration at 250 ml per hour, or C. metolazone 5 mg orally once daily, or would it be D. dopamine 2 micrograms per kilogram per minute IV infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. metolazone 5 mg orally once daily. Because the continuous infusion of furosemide is already at or near a commonly accepted maximum infusion rate, i.e., 20 to 40 mg per hour, and further increases are unlikely to produce substantially greater diuresis, an appropriate intervention would be to use sequential nephron blockade with a thiazide-type diuretic such as metolazone or chlorothiazide. That makes answer C correct. Answers D, B and A are incorrect, primarily because of the patient's renal function. Dopamine in answer D is incorrect because several studies have shown that it does not improve congestive symptoms, particularly among patients with renal dysfunction at baseline. Refer to the ROSE trial. Although ultrafiltration, in answer B, remains an alternative in patients with refractory symptoms despite an adequate trial of pharmacologic therapy, it was associated with worsening renal function among patients with pre-existing renal dysfunction in the CARIESSHF trial. Finally, tolvaptan, in answer A, was associated with worsening renal function in the TACTICS-HF trial. Although the patient has mild hypovolemic hyponatremia, she is asymptomatic. Also, tolvaptan would be less likely to be effective given her worsening renal function. Please proceed to the next question. And the next question reads, APR, a 57-year-old male patient has been transferred to the cardiac ICU at your facility by your consultant cardiologist to be evaluated for placement of a ventricular assist device or cardiac transplantation. He was initially admitted at the outside facility with congestive symptoms, which didn't resolve despite aggressive diuretic therapy. He has a past medical history significant for ischemic cardiomyopathy with an ejection fraction of 15%, type 2 diabetes mellitus and hyperlipidemia. Before transfer, the cardiologist placed a pulmonary artery catheter, which revealed the following: pulmonary capillary wedge pressure 24 mm of mercury, cardiac index 1.6 liters per minute per meter squared, and systemic vascular resistance (SVR) of 1100 dynes per second per centimeter to the power of -5. On admission to the cardiac ICU, APR is confused. His pertinent vitals include a blood pressure of 90 systolic and 52 diastolic, and a heart rate of 82 beats per minute. His pertinent labs include a serum creatinine of 3.2 mg per deciliter. The baseline value was 1.4 mg per deciliter. His aspartate aminotransferase is 132 units per milliliter, alanine aminotransferase is 121 units per milliliter, and the N-terminal pro-B-type natriuretic peptide is 9,450 nanograms per milliliter. So my question to you is, which of the therapeutic options listed below would be most appropriate to initiate in APR's clinical scenario now? Would it be A. Milrinone 0.375 micrograms per kilogram per minute IV infusion, or B. Dobutamine 3 micrograms per kilogram per minute IV infusion, or C. Nitroglycerin 50 micrograms per minute IV infusion, or would it be D. Nitroprusside 0.3 micrograms per kilogram per minute IV infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Dobutamine 3 micrograms per kilogram per minute IV infusion. Given this patient's cardiogenic shock, in the absence of elevated SVR, therapy should be aimed at improving cardiac contractility rather than further reducing afterload. Nitroprusside and nitroglycerin are incorrect because additional reductions in afterload are unlikely to considerably improve left ventricular performance and probably not to the degree necessary to restore end organ perfusion. That makes answers D and C incorrect. Between dobutamine and milrinone, dobutamine would be safest because it is less likely to cause hypotension and less likely to accumulate, given the patient's existing renal dysfunction. That makes answer B correct, and answer A incorrect. In addition to the risk of drug accumulation, an initial milrinone dose of 0.375 micrograms per kilogram per minute is too high and might further worsen hypotension. Please progress to the next question. And the next question reads, your cardiac team is preparing to discharge a 68-year-old female patient whom they admitted and have been managing for acute decompensated heart failure and volume overload. A follow-up is scheduled in 7 days' time, but the team would like to continue diuresing her, given evidence of residual congestion on physical examination. So my question to you is, which of the following best describes the diuretic regimen that would be about equipotent to furosemide 40 mg IV twice daily? Would it be A. Metolazone 5 mg orally twice daily, or B. Furosemide 40 mg orally twice daily, or C. Torsemide 40 mg orally once daily, or would it be D. Bumetanide 4 mg orally twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Torsemide 40 mg orally once daily. Although equipotent ranges for loop diuretics vary because of the wide range in response to furosemide, the two most common equivalence ratios are bumetanide 1 mg to torsemide 20 mg to furosemide 20 mg intravenously to furosemide 40 mg by mouth, and bumetanide 1 mg to torsemide 20 mg to furosemide 40 mg intravenously to furosemide 80 mg by mouth. In either case, bumetanide 4 mg by mouth twice daily would be too high and furosemide 40 mg by mouth twice daily would be too low. That makes answers D and B incorrect. Metolazone is generally ineffective as monotherapy in heart failure. That makes answer A incorrect. Torsemide at a dose of 40 to 80 mg once daily would be an acceptable equipotent regimen to furosemide 40 mg intravenously twice daily. That makes answer C correct. Please proceed to the next question. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 198.